Hello, everyone. Thank you for joining us today. I am going to give some time for everybody to come in from the lobby. I see you all there, and then I'll get us started right at the top of the hour. We've done lots of things for this series, but one thing I've not done is create theme music yet, and I think we need it. We need a little music right here.
Just gonna mute all.
Go. Okay, well, I'm going to go ahead and get us started. I do see some people still in the lobby. I'm sure they'll filter in. But first, hello, and everyone, welcome to the Rural Health Executive Educational Series. I am Cody Smith, Director of Rural Partnerships and Leadership Development at NRHA Service Corporation, and I am thrilled to be your moderator today. Before we dive in, just a few things you should know. This session is recorded, and we'll be sure that we email the recording to everyone who registered later today. So no need to scramble for those notes. You'll have everything at your fingertips. At the end of the session, we do ask for your feedback through a short survey. Your input really does help me make these sessions as relevant and useful as possible for you and your peers. A few housekeeping items. All attendees are muted to ensure the session runs smoothly. The presentation should last around 45 minutes. This will give us some time at the end for some question and answer. If you have a question though, don't wait. Go ahead and drop it into the question section of your control panel at any time or as it comes to mind. This is your chance to talk to Dr. Bevan and get advice tailored to your unique needs. Today, we're thrilled to welcome an incredible speaker, Dr. Carolyn Bevan. As someone who personally navigates life with multiple sclerosis, I understand how vital early diagnosis and specialized care are, especially in rural areas where access to expertise can be a challenge. So having Dr. Bevan, who's worked with the VA National Neurology program, where it focuses on improving access for rural populations and ensuring even the most remote communities receive support, is very exciting for me today. Dr. Bevan, thank you so much for joining us. So with that, I'm going to go ahead and hand it over so we can dive in.
Wonderful. Thank you so much. It's really a pleasure and an honor to be here and to be able to speak with you. I do a lot with rural health through the VA and reaching veterans who have who live in areas with limited access to care in rural places. And so it's really meaningful for me to be able to reach out and talk to you guys. And I'm so interested to hear what your experience is, and hopefully we can have a good discussion at the end of this talk. I think we're gonna start with a few survey questions. So I'm gonna throw it back and maybe we can get those started.
Absolutely, thank you so much. So I'm gonna start us off. Our first poll, how many patients with multiple sclerosis are you currently serving? I am so sorry, my words do not want to come out today. Your choices are 0, 1 to 10, 11 to 25, 26 to 49, or 50 and over. I'll go ahead and leave that up for a minute so you guys can go ahead and respond, and then we will share the results to talk about it. And we'll have one more poll after this. I'll leave it up just for a couple more seconds. So again, how many patients are you currently serving? All right, I'm gonna go ahead and close this one and share the results with you. Be 1 second. Okay. So Dr. Bevan, it looks like about 57% of people on today have 0 patients.
Okay.
And then 14% are 1 to 10, and then 29 are 26 to 49.
Wow. Yeah, great.
Yeah, let me go ahead and, there we go. And then I'll go ahead and do the second one. Would you like me to?
Absolutely.
Wonderful. Go ahead and launch that. How familiar are you with multiple sclerosis? So not at all, slightly, somewhat, moderately, or extremely. I'll leave that open for everybody to vote. Again, how familiar are you with it? So not at all, slightly, somewhat, moderately, or extremely. Okay, leave it open for a couple more seconds. All right, go ahead and share those results with you now. It looks like about 14% of the people with us today say they're not at all familiar, and then 14% are somewhat, and about 70% are moderately.
Okay, that's a good mix. I think this talk hopefully will have something for everyone. For the folks who don't have patients with MS. I suspect that you will at some point. We'll go over some of the epidemiology of MS. For those of you who are very familiar, hopefully, or moderately familiar, you'll still hopefully learn a few things today about multiple sclerosis. And we're really focusing on the earliest signs and symptoms of multiple sclerosis. So kind of at the very beginning, how do you identify MS and what can you do to help with the diagnosis and when to refer to a neurologist? Perhaps, let's see. Oh, there we go. All right. So disclosures. I will be discussing a few things that are not FDA approved indications. So I'll make sure to flag those. So our objectives today, we are going to learn about the landscape of neurology care in the US, including some focus on kind of rural access to neurology care. Then we're going to switch into multiple sclerosis, kind of what it is, environmental risk factors, genetic risk factors, and then really dive into the symptoms suggestive of multiple sclerosis, things that you should listen for or watch for, and then finding out kind of with one first symptom, can we make the diagnosis of MS? So that kind of idea of the space and time criteria that we'll go over. And then thinking about the importance of early recognition and initiation of disease-modifying therapies for MS. So just an overview, just our road ahead here. I think we kind of will remind ourselves where we are along the way. But first, a patient story. So this 26-year-old woman with previously treated depression presents with a 2-day history of decreased visual acuity and pain on eye movement involving the right eye. She has symmetric pupils, they're reactive to light. However, she has a relative afferent pupillary defect on the right. Her visual acuity is 20/60 on the right versus 20/20 on the left. And a fundoscopic exam is unremarkable. This was going to be a video in an afferent pupillary defect for those of you who have not seen it, but we were not able to make it work today. Oh, maybe something is happening. Let's find out.
Yeah, it'll play, it just won't have sound.
Oh. So this shows that in a dark room, this pupil constricts, but this pupil actually dilates. So normally both pupils constrict. However, when the light is shined into the affected eye, it perceives less light, and therefore it dilates when you shine a light in it. So that's what an afferent pupillary defect looks like. All right. All right, now, see if we can move on. Okay. All right, so you get an MRI. Now, in a person with optic neuritis, you would get an MRI of the brain, but also the MRI of the orbits to really get a careful look at those optic nerves. And so here you can see that there's enhancement of the optic nerve on a T1 post-contrast image, but she also has these T2 flare hyperintense lesions that are periventricular and kind of ovoid appearing. And then because you're thinking about dissemination in space, which we'll talk about more, you also look in her spinal cord and you see that she has incidentally these 2 non-enhancing lesions in her cord. So, does this woman have multiple sclerosis? So we're going to answer that question, but first, just an overview of access to neurology care in the United States. We know, and I'm sure that you feel every day, that there's a shortage of neurologists in the United States. So there are 13,853 active neurologists. That gives us a total of 23,574 people per active neurologist. So not enough of us. And I know in primary care, similarly, we're all stretched very thin. And then on top of that, there's this geographic disparity in neurology care. So 15 to 20% of the US population is classified as rural. And in a study looking at neurologists and neurology advanced practice providers, there were 24,658 providers in the NPI registry. Of those, about 3% had a primary practice location in a rural county. And of 2,014 rural counties in the US, only 20% had at least one neurologist. So we are few and far between. So oftentimes our primary care is kind of left trying to at least get things started for people who are experiencing their first symptoms of multiple sclerosis. And MS is actually more common than we thought. So the MS Society funded this reevaluation of the numbers of the MS prevalence in the United States, and it seems like nearly 1 million people in the United States are living with multiple sclerosis. So this is about twice as many as we had previously estimated, and the prevalence is increasing. So I know some of you don't have patients with multiple sclerosis, but at some point it's likely that you'll come across one. And early diagnosis makes a difference. And so on this table on the left side of the screen here, you can see this is time to EDSS-4, which is a summary scale reflecting more moderate disability. It's on a scale of 1 to 10. And you can see here treatment start from MS onset. So within a year, 1 to 3 years, and more than 3 years. And you can really see the spread of people who have early versus later onset treatment and how that makes a difference in the likelihood of them achieving a moderate disability time point. And then also, we know that people with relapsing forms of multiple sclerosis transition to secondary progressive MS. And it used to be that we would say that around half of people with relapsing MS transition to secondary progressive MS. This was based on studies that were performed in the 90s and early 2000s. However, in a more recent study published in 2016, it looks like that curve is actually shifting out. So fewer people are transitioning to secondary progressive MS. And we think that's because we're able to make the diagnosis earlier and start them on treatment earlier. And so perhaps we're kind of pushing that curve out. So there's a delay and fewer people are reaching that transition to secondary progression. So what is multiple sclerosis? How do we define it? So we know it's a chronic inflammatory demyelinating disease of the central nervous system. And there's a component of demyelination. So myelin is the fatty covering of the nerves. However, we also know that there can be axon loss. And so there is somewhat of a degeneration that can occur in multiple sclerosis as well. Usual onset is kind of in the early to mid 30s. There's a female to male ratio of 3 to 1, but that's increasing. And there are both environmental and genetic risk factors that we'll go over in more detail. In terms of the genetic risk factors, so the population risk of 0.1%, but if you have a first degree relative, it increases to 3%. So if a parent has multiple sclerosis, the likelihood of a child having MS is still very low, but certainly higher than the general population. In monozygotic twins, there's a 30% concordance rate. There are a lot of gene variants. So this is a genome-wide association study here. Of those, HLA-DRB11501 is the most important, and that's kind of an immune marker for our cells. But this is a very common gene in the general population, and most people with this gene don't end up getting multiple sclerosis. So it's not just a kind of like direct effect of a gene. So the environment actually plays a very important role in the development of multiple sclerosis. It seems that there's a latitude pattern. So the further away from the equator, the more kind of prevalent MS becomes. And this could be because of vitamin D. There could be different environmental pathogens. There could be shared genetic overlap in some of these populations. We also know that tobacco, early life obesity, are risk factors, and then viruses, especially EBV exposure, really seems to be a risk factor for multiple sclerosis. Low vitamin D, and then maybe microbiome. So we're looking a lot at differences in the microbiome of the gut and other organ systems, and thinking about whether there are differences in the gut flora that also may predispose to multiple sclerosis. There are different phenotypes of multiple sclerosis, and I know this is a busy slide, but just thinking about kind of the very beginning of things. So the preclinical stage or radiologically isolated syndrome. And what I want to point out here is this curve is brain volume. And as we think about the importance of early diagnosis and early initiation of treatment, we see that brain volume is already dropping early in the disease before they even get to clinically isolated syndrome or relapsing multiple sclerosis. And then we have primary progressive MS here. So this is kind of reflective of the importance of early diagnosis, that we have all of this activity that's kind of happening below the surface, and then it eventually breaches above, causing relapses and then accumulation of disability over time. So we're going to focus on this early part of the chart here. We're not going to talk very much about secondary progressive MS today. So let's start with that radiologically isolated syndrome. I just want to mention this because as primary care providers, you may get MRIs on patients for various reasons, and sometimes you actually find incidental white matter lesions. And some of them look demyelinating, but the patient has never actually had a symptom of multiple sclerosis. So this idea of radiologically isolated syndrome, so this is MRI with incidental white matter anomalies that are highly suggestive of demyelinating disease. This is not your 60-year-old patient with small vessel ischemic changes. These are lesions that radiologically very much look like demyelinating lesions. And we know that the overall risk in these people of going on to develop a clinical event at 10 years is about half. But it ranges a lot depending on what their risk factors are. So if they're younger, if they have cord lesions or infratentorial lesions, meaning brainstem or cerebellum, and then if you do a lumbar puncture and they have clonal bands, that can all increase their risk. So if you get an MRI for your patient with a migraine, or somebody gets in a car accident and they get an MRI of their brain, this is actually a growing kind of entity as MRI is becoming more available. And then we move on to clinically isolated syndrome. So this is when a clinical event has occurred. And we think of clinically isolated syndrome as a demyelinating event, but where the person doesn't necessarily otherwise meet that space and time criteria for the full diagnosis of multiple sclerosis. So if in their first episode, they have other T2 hyperintense lesions, they have bands, if their vitamin D levels are low, that changes their risk of going on to develop multiple sclerosis. So you can see here in the lowest risk group where they have no bands, they have minimal lesions, vitamin D is good. They have a low risk of converting to multiple sclerosis at 2 years and 5 years. However, at the highest risk group, and really at this point, we would consider this just multiple sclerosis if they have that many other lesions most of the time. But you can see that at 5 years, the majority of them will go on to develop multiple sclerosis. And so that's why for high risk clinically isolated syndrome, we do offer disease modifying therapies even for in this group. And then we go into the relapsing form of multiple sclerosis, which is the most common kind of MS. So this is defined as discrete relapses with variable recovery. And some of these patients may transition after a period of 15 to 20 years to a different, more progressive course of secondary progressive MS. So what is a relapse? We'll go over some symptoms of relapses in the coming slides. But basically, a relapse is a set of neurologic symptoms that last at least 24 hours, usually peak in days to weeks, and they're not explained by other etiology. So sometimes a person with MS will have worsening symptoms, but they'll have a fever, or they have a UTI, or they haven't been sleeping well, and so their kind of chronic symptoms kind of act up. We wouldn't call that a relapse, we would call it a pseudo relapse. However, it's kind of difficult sometimes to really be sure of what's going on. And then I also just want to make sure to mention primary progressive multiple sclerosis. So this is where instead of having discrete episodes or attacks with recovery, there is an insidious accumulation of disability over time. And this is a slow course. So the story is kind of like, I noticed that when I would go for a jog, my right foot would kind of drop. And then like over the following months, my right leg would kind of drag even when I was just like walking normally. And now I'm starting to notice it in my left leg a year later. So slow, but without recovery. So kind of just more of that progressive trajectory. They still can have relapses, but just the onset is this progressive course. This it happens about 10% of the time, so it is less common than the relapsing form. Usually older at diagnosis, and there's more of a balance between men and women. MRI changes are not as prominent with primary progressive MS, so sometimes they get worse, but their MRI stays the same. We think it's just a different kind of inflammatory response that is different from the kind that forms these lesions in the brain. Now we're going to move on to the clinical presentations of MS. So this is kind of really the meat of the matter in terms of how do I recognize multiple sclerosis? What are the symptoms that I should be watching for? So first, it's interesting, we're kind of starting to learn more about this idea of an MS prodrome. So even before the first clinical event, it seems like people with MS have more fatigue, more pain, headaches, mood changes, bladder issues, and they also seem to have increased healthcare utilization. So they looked at things like hospital admissions, physician claims, drug classes. And this is a Canadian study looking 5 years before the diagnosis. And you can see that there starts to be this uptick kind of as they get closer to their incident clinical event. Now, these are non-specific symptoms. So I wouldn't say that every patient who has fatigue and bladder issues or something like that, like I'm not sure that I would screen with an MRI at this point, but just be kind of mindful of that background. So then let's get to the actual clinical presentation. So what are these first clinical events that are typical of clinically isolated syndrome or relapsing multiple sclerosis? So the optic nerve is one of the most common presentations. About 20% of people with MS have optic neuritis. And usually in MS, it's monocular. It's painful, but it's more kind of like a pain on eye movement. So it's not, you shouldn't see kind of like an irritated red looking eye. It's sort of like an ache where they're like, it just hurts a little. Sometimes they have color desaturation. They'll kind of describe a smudge in their vision. Usually in multiple sclerosis related optic neuritis, the vision loss is not profound, and it usually starts sort of subacutely. So it starts kind of with a smudge and then it gets kind of larger over the day or the following day. It's not something that is, for example, acute onset total vision loss or kind of like the film going down. That maybe should suggest other etiologies. And then the other very common presentation of CIS and relapsing MS is spinal cord. So partial myelitis is really common as well. So in this case, you might see a sensory level. So they describe this. There's something called the MS hug, where they feel this kind of like band-like sensation that sometimes makes it hard for them to breathe. And they'll say like everything below this line feels numb. And sometimes you'll actually see a Brown-Séquard syndrome. So you can see that here. So here's kind of the anatomy of the spinal cord. So we have the dorsal columns where sensory pathways are, and then we have the kind of anterolateral pathways where the motor things are. And we know that vibration and proprioception sense and motor, they kind of stay ipsilateral in the cord until we get higher up into the brainstem, and then they cross over. Whereas temperature and pain decussate immediately and then cross. So you can get these crossed findings where pain and temperature are reduced on one side, and then vibration, proprioception, and the motor findings are down on the other side if kind of a larger lesion affects kind of that half of the spinal cord. And so those are other things to watch for. In spinal cord, if there's a cervical cord lesion, you might hear about something like a Lermite sign, where if somebody puts their chin on their chest, they feel a shooting pain that goes down the back. It's not just a kind of an achy neck thing. It really shoots down all the way down their back. So that's another common kind of spinal cord sign. And then other presentations, so brainstem, so intranuclear ophthalmoplegia, so where one eye can't cross midline to adduct, and then you have this abducting eye nystagmus. So that's where the yoking mechanism in the midbrain is affected. So the eyes are not moving together. So that's a common presentation of multiple sclerosis. And then a lot of other things like ataxia, vertigo, tremor, trigeminal neuralgia is another one that can be from a brainstem lesion. And even at Bell's, actually, even though we think of it as peripheral, we have seen facial paresis as a presentation of multiple sclerosis too. Cerebral hemispheric lesions are less commonly symptomatic. They're more often incidentally found, but they can be symptomatic. And then you kind of see more face, arm, and leg hemibody paresis or sensory disturbance. So if you have things like fever, or if you have a large longitudinally extensive myelitis, these are kind of alterations of consciousness. These are odd and should kind of make you think of other etiologies. Now, I also wanted to review the presentation of progressive multiple sclerosis. I already mentioned it's this insidious progression over time. So this is kind of our disability scale. And you can see here someone is walking fine and then kind of maybe slowing down at EDSS of 6 using a cane, wheelchair, walker. And the symptoms are similar to what people with relapsing MS have, but they occur much more insidiously rather than over days. So they have cognitive changes. They can still have intranuclear ophthalmoplegias, although diplopia that's symptomatic is less common because it kind of creeps up almost in a way that the brain has enough time to sort of rewire itself around it. So oftentimes you'll just see the INO on exam, but they won't say that they have double vision. Dysarthria, dysphagia, bowel and bladder symptoms, cerebellar symptoms, so like ataxia, hyperreflexia. So sometimes it's hard to know if someone presents with weakness and numbness and they have reduced reflexes, they have a neuropathy, but remember we should be seeing upper motor neuron signs. So spasticity, hyperreflexia, Babinski's, Hoffman's, these are pointing more to a process affecting the brain and the spinal cord. And then people with multiple sclerosis, I'm sure those of you who have patients who have multiple sclerosis know this, there are many, many symptoms of multiple sclerosis, including between attacks. So we call relapsing MS relapsing remitting, but I feel like the remitting part is a little bit misleading because most people with MS have symptoms that they experience even when they're not having an active attack. Fatigue is a really big symptom, nerve pain, vision changes, cognitive symptoms. These are all things that affect many people living with multiple sclerosis, whether they're having active disease or not. Now we're going to move on to diagnosing multiple sclerosis after a single clinical event. So we have this patient who has one episode. Is it possible for us to say that they have a chronic demyelinating disease? So the concept that we have to prove to say that they have MS is separation in space and time. Space, we can use MRI to demonstrate dissemination in space after a single clinical event. So we don't have to wait for a second event to hit somewhere else. We can just look at the MRI. So there are 4 spaces that kind of qualify for dissemination in space. We have the periventricular lesions, so these ovoid lesions that are kind of perpendicularly oriented, and they're touching the ventricle. And these are Dawson's fingers. Callosal lesions are also included in that, and they actually are more specific for demyelination than periventricular lesions, which I think those of you who have large patient populations know many people have periventricular lesions that maybe don't end up having MS. Brainstem lesions, so this would be the location of a lesion for an INO. Juxtacortical lesions, so lesions, this U shape kind of touching the cortex. So again, this is not the subcortical small white matter changes. This is a little bit more of a unique appearance, this juxtacortical or cortical lesion. And then spinal cord. Spinal cord also is very specific to a demyelinating process rather than migraine changes, small vessel ischemic changes, things like that. And to demonstrate dissemination space, you have to have at least one lesion in at least two locations. So if you have a periventricular lesion and a cord lesion, that would qualify as dissemination space. So thinking about our patient that we started with, that's why maybe it's helpful to get the spinal cord in addition to the brain. You don't necessarily have to get it all at once, but if you see that someone has an optic neuritis, let's say, and you get the MRI of the brain and maybe they have a periventricular lesion, you think, okay, if they have one periventricular lesion, are they going to have cord lesions? Would that change my impression? It probably would. So it might then be useful to go ahead and order that MRI of the cervical and thoracic spine to get the full spinal cord view. And then to demonstrate dissemination in time. So again, that idea of a chronic process rather than a monophasic process. So we can do this again on MRI by demonstrating that there are both enhancing lesions and non-enhancing lesions. So if there's simultaneously enhancing and non-enhancing lesions, we can say that there are old lesions and there are new lesions, and that's it. However, sometimes someone will come in many months after a symptom has already resolved, and you'll get the MRI and they'll have demyelinating lesions, but they're all non-enhancing. So in that case, you could then obtain a lumbar puncture. And if they have unique oligoclonal bands in their spinal fluid, that implies that the immune system has kind of set up shop in there and it's kind of secreting these antibodies chronically. So that is a chronic inflammatory response that is inside of the central nervous system. So that is a surrogate marker for separation in time. So just remember that really not everyone needs a lumbar puncture at this point to make a diagnosis of multiple sclerosis. So you're not obligated to send someone for a lumbar puncture if they have otherwise typical clinical event, typical lesions that meet criteria for dissemination in space and time. The MRI, the lumbar puncture is not required. How about the mimic? So there's no blood test or spinal fluid test or any test that is absolutely diagnostic of multiple sclerosis. We kind of have to put it together and exclude mimics. So what are some mimics? We talked about things like ischemic optic neuropathy. There are hereditary optic neuropathies. And then there are other inflammatory diseases like sarcoid or NMOSD or MOGAD, infections like syphilis, Lyme, neuroretinitis, like these are all things that can mimic optic neuritis in terms of brainstem syndromes, of course, ischemic things, other inflammatory diseases, infections, and then certain vitamin and nutritional deficiencies. With myelitis or myelopathy, we always want to make sure we're not missing cord compression. People can have strokes of the spinal cord, they can have vascular malformations of the cord. Other autoimmune diseases like NMO and MOG affect the cord as well, more rarely some of the other autoimmune conditions. And then viral myelitis and myelopathies related to B12 deficiency. Copper deficiency would be more differential progressive myelopathy. Same with HTLV, more of a differential for like primary progressive MS. So, I think it's hard to always come up with the perfect list of what should I exclude in mimics because every case is a little bit different and has clues in it that might point you one way or another. But I think if you start off by evaluating for syphilis and HIV and Lyme, tuberculosis, if it looks kind of infiltrative, check a B12, a thiamine, an ANA, which can be low level positive in people with MS, so it doesn't exclude MS if it is, Sjogren's, and then possibly NMO and MOG if they present with something that's kind of in that spectrum of optic neuritis or a kind of a larger cord lesion. So these are all things to just think about or maybe get cooking as you kind of go through the confirmatory process. So back to our case. So does this woman have multiple sclerosis? So remember that she presented with a unilateral optic neuritis. So she has an enhancing lesion in the optic nerve. Now, as of the current criteria, that will change, the new criteria, but as of our currently published criteria, the optic nerve is not a space, but she has periventricular lesions, She has cord lesions, so she has at least one lesion in at least 2 spaces. And then she has simultaneously enhancing and non-enhancing lesions. So she had an attack and she has dissemination in space and time based on the MRI. So she would meet criteria for relapsing multiple sclerosis. Now I'm just going to briefly review treatment. So sometimes, because neurology is hard to come by in rural areas, you actually might be faced with treating somebody for an MS relapse as they kind of get in to see their neurologist. And I know that in my experience, sometimes it can even be hard to access IV solumentrol, for example, because of it has to be infused, and sometimes the emergency room is overwhelmed, and it just can be hard to arrange. So we know um, the standard of care historically to treat a relapse has been IV solumentrol, 1 gram daily for 3 to 5 days, followed by a taper. And this is based on the optic neuritis treatment trial from 1992. They looked at 3 groups of people and tried to figure out who would recover best. The IV solumentrol high dose group, the low dose oral prednisone group, or placebo. In fact, everybody recovered to the same visual acuity, but the high dose steroid group got there faster. So, and then oddly enough, the oral low dose group had an increased risk of subsequent episodes of optic neuritis. And so there was this feeling in the community for many years that you should absolutely avoid oral steroids because that seems like maybe it increases risk of a subsequent event. However, I think we can appreciate that these are not the same doses of prednisone. So subsequent trials on the right side of the screen looked at whether bioequivalent doses of oral corticosteroids would actually be adequate. So they looked at the equivalent dose is 1,250 milligrams of prednisone. That ends up being 25 pills of 50 milligrams of prednisone. So definitely something you'll have to call and confirm with your pharmacist if you're going to go this route. But if you're in a pinch and can't get the IV solumentrol, oral large doses of steroids are non-inferior. And really, in terms of the GI side effects and other side effects of steroids, these are really more because of systemically mediated effects, not because of like direct kind of contact with the steroid and the lining of the stomach. So the side effect rates are similar. So if you would give someone uh, 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 like a GI prophylaxis for an IV solumentrol, you would do the same thing for oral. If they're low risk, you may not. Same thing. So just something that I think in the rural setting actually could be helpful to you, and maybe something that, if you can't get someone in to see a neurologist and the emergency room options are hard to come by, just something to keep in mind. Now, I think that for more severe relapses, I would still send someone to the emergency room, certainly if they have lost vision or they're not safe at home, they're falling, they're not able to walk. These are reasons to just go ahead and send them in. But if you feel like they are safe at home and maybe you just want to kind of treat them and help them avoid having to go to the emergency room, this would be something to consider. And then comes the long-term disease-modifying therapies. And we live in an era where we are fortunate to have many of them. There are over 20 different disease-modifying therapies. And I think it's probably beyond the scope at this point of most primary care practices to really give a detailed kind of overview of these disease-modifying therapies. But I feel like what I would hope that you communicate is that there are many treatments and treatment is sort of personalized. However, it's important to start early. So we know, we looked at the slides earlier in this presentation, and we know that the longer you wait, the more likely you are to reach kind of higher disability milestones, potentially increased risk of transition to secondary progressive multiple sclerosis. And really for the same reason, we've changed our paradigm of disease modifying therapies from an escalation approach where we start with kind of the more modestly effective older disease-modifying therapies and then escalate if someone breaks through, we really have learned that the most benefit of all of these disease-modifying therapies really happens with early initiation of treatment. And so now we really offer people with multiple sclerosis a highly effective disease-modifying therapy right from the start, rather than waiting for them to get worse, because we've learned that we're much better at preventing something from going wrong than going back and trying to fix it after it's already occurred. So that's kind of a paradigm shift, I think, from kind of prior treatment approaches. And you can also tell your patient, there's a lot out there. Go ahead and start to read about it. And while you're waiting to see the neurologist, the National Multiple Sclerosis website has really detailed patient information about all the disease modifying therapies. And sometimes it's helpful to kind of familiarize themselves if they feel comfortable with some of the names and kind of start to think about what's important to them and what they want to ask about at that visit. Of course, the medicines that we use, the immune medicines, are really just part of the overall approach to caring for someone with multiple sclerosis. So things like diet and exercise counseling, tobacco cessation are really important. We work a lot with our colleagues in PM&R, physical and occupational therapy, speech therapy, a lot of patients with neurogenic bladder and bowel, neuropsych, social work needs as they navigate kind of what to do about their workplace, kind of the emotional impact of a diagnosis of multiple sclerosis and that kind of adjustment period that can come. And then there are a lot of complementary alternative approaches, acupuncture, that can be really helpful at just managing the day-to-day with multiple sclerosis. I just wanted to put a plug in because I just appreciate so much the role of primary care in keeping our patients with MS healthy. I think this demonstrates here, EDSS-6 is walking with a cane. And you can see the difference between people who have never smoked versus people who have smoked, in terms of what the proportion who remain below an EDSS of 6. So smoking cessation is really important and can impact outcomes. And then also we're learning a lot more about how different medical comorbidities impact the outcome of multiple sclerosis. So you can see ischemic heart disease here, higher risk of disease activity, diabetes, and then here, hyperlipidemia, again, diabetes, ischemic heart disease, in terms of disability worsening. So we know that people who are healthier overall also do better with multiple sclerosis. So it's such an important partnership that while the neurologist kind of is managing the neuro symptoms and the immune therapies and things like that, your role is so important in keeping these folks really safe and at their best performance in the long term. And I'd like to end just by pointing towards some resources because, as we've said, it can be a wait to see a neurologist. And in the meantime, it's really an opportunity for patients to educate themselves. But in a world with internet craziness and a lot of misinformation, it's important to point people to the right resources. So the National Multiple Sclerosis Society has fantastic resources for patients if they're newly diagnosed and just trying to understand what MS is, if they want to kind of get more into the details and read about the different disease-modifying therapies, if they need support for their care partners. There's also this MS Navigator program where you can refer a patient and the navigator will help connect them with local resources, figure out where the MS center is that might be close to them, educational resources for different patient groups. So really a lot of resources out there to help support your patients even before they are finally able to see a neurologist. So this is a QR code here for the MS Navigator and some contact information. I know this is recorded, so you guys can always reference this slide. And in addition to patient resources, there are also resources for you. So, let's say you're thinking about vaccinating somebody and you're not really sure if it's okay or what should you do. Things that come up in practice, and maybe you don't always want to like track down the number for their neurologist. You just kind of want to see if you can figure it out on your own. So just general information on MS, the diagnosis, different recommendations for management, and educational resources, and certainly appreciate the MS Society collaborating on this educational content as well. Another QR code for you. So I think we are at the end of our talk, as we've navigated our learning objectives and hopefully have a better sense of neurology in rural settings, risk factors for MS, signs of MS, how we diagnose MS with kind of a single clinical event, and the importance of starting a disease-modifying therapy early in the disease course. So thank you so much for attending. I really appreciate your interest, and I'm open to questions.
Great, thank you so much, Dr. Bevan. It is time for our Q&A now, so if you haven't already, please go ahead and type your questions into the GoToWebinar control panel. It's a great opportunity to hear directly from Dr. Bevans and get some advice that you're looking for, so don't hold back. We're ready to answer. Dr. Bevan, I'll start us off with question number 1. You mentioned that it's important to start therapy early after diagnosis. What's the ideal treatment?
Yeah, so there is not necessarily an ideal treatment that's the same for everyone, but we think of the highly effective disease-modifying therapies as for relapsing patients as usually it's going to be either one of the B-cell therapies, so things like ocrelizumab or ofatumumab, ublituximab, or natalizumab or Tysabri. So those are kind of the more highly effective disease-modifying therapies that we think of as like a starting for a newly diagnosed patient. But we have to really take into account a lot of other factors, the type of multiple sclerosis they have, other medical conditions or history that may impact risk factors, and also just what's important to them, what their family planning might be. So there's a lot that goes into that decision about the right disease-modifying therapy. Thanks for that question.
Thank you. Okay, go ahead and put your questions in that panel now. We'll be sure to address them. Another question for you, Dr. Bevan. Are there therapies available to repair damage that's already been done in the CNS?
Yeah, so there are some early trials looking at remyelinating and repairing agents. There was a trial of an old antihistamine called clemistine that showed that there was some potential remyelination and repair. The downside of that is that it kind of has a Benadryl-like effect of just making everyone super sleepy all the time. So they're kind of still honing in on that mechanism and maybe developing a drug that has a more targeted effect. And then there are many other drugs in the pipeline with that same effect, but nothing that is FDA approved. There is dalfampridine or Ampira, which is not a medication that remyelinates. However, it improves the ability of a signal to be transmitted along the axons. So it was studied in walking in multiple sclerosis, and it was shown to improve walking speed. So if someone has a mobility impairment, it may be something to offer. It's not an immune modulatory medication, but it can just sort of like improve the transmission of those nerve signals. So it kind of works that way. Contraindicated in people who have epilepsy. It can cause insomnia. It's a twice-a-day medication. And it gets excreted through the kidneys, so if people have renal failure, to be careful there. And there are responders and non-responders. So I usually do a 2-month trial of dalfampridine, and then if it doesn't really seem to help, then we usually taper off of it. Good question.
Okay, thank you so much. Could you talk a little bit about how telemedicine addresses geographic disparities in neurology care?
Yeah, so, I think we had this experience in the pandemic where sort of like suddenly all the barriers were just disappeared for telehealth, and we could provide care across state lines. And so someone living in a city in one state could provide telehealth care to someone living in a rural environment somewhere else. Now the barriers have reestablished, so there are some difficulties in reaching out to those folks who live in rural communities. I work at the VA, and so we have, since it's a federal organization, it's a lot easier for us to provide care across state lines. And so there's a program called the National Neurology Program, where we have sites around the country in different rural settings, and we provide neurology care through those sites. But otherwise, I think even though there are these barriers of kind of state lines and things like that, I think telehealth really provides an opportunity for people who live far away from the nearest academic center, that we can reach out to them much more easily. Maybe, I do think there is value to the neurologic exam. And so for someone who's newly diagnosed and you really want to make sure you understand what's going on, it is really helpful to see them in person. But sometimes perfect is the enemy of good. And certainly if someone lives very, very far away and the best they can get is a specialist on a telehealth visit, then I think that's still really meaningful, just because there's so much to learn and know about multiple sclerosis. So access to that expertise is really important.
Great, thank you. Another question that came in for you is, could you elaborate a little more on the connection of EBV, so
Yeah.
Epstein-Barr?
Yeah, so it seems like there might be a molecular mimicry going on. We're not totally sure, but they actually looked, this was actually in a VA DoD study, looking back at serum EBV positivity in people who were eventually diagnosed with multiple sclerosis. Now, EBV is obviously a very common virus in the general population. So like 80 to 90% of us will have a positive EBV titer. However, 100% of people with MS have EBV. And one of the researchers in the study proposed that MS can be characterized as a rare complication of EBV infection. And so what might happen is that somebody who has kind of those variants of cell proteins where antigens bind, and then so the EBV viral particle binds, and then maybe it looks a little bit like myelin. And in somebody who perhaps has a kind of a genetic problem with their immune system, where there's a failure of tolerance and kind of an allowance of autoimmunity, this kind of triggers the immune system to kind of attack myelin and sort of triggers this chronic immune response. I'm not totally sure, but it really seems like there is a link between EBV and risk of multiple sclerosis. And there's actually research about EBV vaccination and whether people who, for example, have a family member with MS or have other risk factors, whether vaccinating against EBV could actually reduce the incidence of multiple sclerosis. So interesting.
Thank you. A follow-up question to that, how do we as providers reassure patients without creating this unnecessary fear of EBV?
Yeah, so I think the bottom line is that EBV is just such an incredibly common virus that almost all of us get exposed to. And MS, while it is, more common than it has been in the past, remains fairly rare. So I think that we all get exposed to many different viruses in our lifetime, and the vast majority of us are not going to develop a condition like multiple sclerosis in response to that exposure.
Okay, go ahead and put those questions in if you have them. We've got a couple more minutes. I could probably get one or two more in. One that just came in, what are some atypical symptoms that we might often miss?
Yeah, so that's a good question. Going back to the MS prodrome and that kind of increase in fatigue and brain fog, it's hard because those kinds of symptoms are so nonspecific that if you got an MRI for everyone that came to your office with those symptoms, you would get an MRI for like half the patients you see in a day. So that can be pretty tricky. I think that that's the reason that when we developed the MS criteria, we kind of focused on symptoms that are localizable. And so, you can have a lot of the nonspecific symptoms, but really they should localize to something that would make sense in the nervous system, like the optic nerve or the brainstem or the cerebellum. So there should be some focality. So it would be atypical to just have all kind of, migratory paresthesias that last less than 24 hours, or kind of weakness that comes and goes throughout the day. So that would be, less typical of multiple sclerosis. Now, some of the MS mimics. So for example, NMOSD, so neuromyelitis optica, which is also something that can cause optic neuritis and myelitis. So usually that's more often a severe optic neuritis. It can be a bilateral optic neuritis. The myelitis is longitudinally extensive, so it extends longer than 3 vertebral segments. So if you see a very large lesion, that kind of may suggest something like neuromyelitis optica. And then MOGAD, sort of similar actually, bilateral optic neuritis, longitudinally extensive myelitis. So these are things that really should make you start to think about mimics of MS. I think the other atypical thing is that we really think of relapsing MS as something that happens in people in their early part of their life, 20s, 30s. But I think what you might notice is that there are people who get diagnosed with MS later on, especially progressive forms of MS. Remember that these folks are getting diagnosed in their 40s and sometimes early 50s. I think the oldest person I have diagnosed with MS was in their early 60s, and they had, a long time ago, this funny spell with their vision and then another funny spell with their right leg. And then they started to kind of progressively get worse later on, years later, and they probably were transitioning into secondary progressive MS after, a couple of relapses that nobody realized earlier on. So there can be some kind of unusual age at presentation, for example, that can kind of throw you off.
Thank you. I think this will probably be our last question, unless somebody else has one more I want to throw in there. Dr. Bevan, you mentioned obtaining MRIs with or without contrast can be a good first step if MS is suspected. As a PCP without immediate access to a neurologist, are there any additional steps like specific labs or symptom management strategies?
Yeah, so the labs, I think screening for B12 deficiency, looking at an ANA, looking at a syphilis screen, HIV test, if they have an optic neuritis or a myelitis or something in that category, it would make me more likely to send off a serum NMO antibody or a MOG antibody. You can check a quantiferon for screening for TB if there's enhancement that looks kind of infiltrative. If there are things that are atypical, like they have a rash or some other things, you could think about sarcoidosis. And you would get a chest x-ray if you were worried about that. So different, there's not like a perfect mimic evaluation because people can present differently, but I think if you think about those things, you're gonna be off to a good start. Lyme is another one. I think that screening for Lyme, I really never see it positive, but I don't live in a region where Lyme is endemic per se. So certainly if you live in New England or some other part of the rural areas with Lyme being more prevalent, certainly check for that as well. That can be a mimic. And so I think that would be a good start. And like I said, not everybody needs a lumbar puncture. So if it seems like it's a more typical case and there's no other question involved, not everyone needs an LP.
Great, thank you so much for all the information. We do have just a couple minutes left. If you will have another question, please go ahead and put that in. In the meantime, Dr. Bevan, I'm going to turn it over to you for closing remarks before I end our session today.
Wonderful. Well, thank you for these great questions. I really appreciate your interest and I appreciate the taking time out of your very busy day. I just want to end, I always like to end on a idea of hope. I know we talked about remyelination repair strategies. We talked about disease modifying therapies, and it's amazing to think that we have so many of them available. But I think that, every time I go to a conference or open a journal, I think I'm so inspired by how much is in our future. And so I think the landscape of multiple sclerosis, there's so much momentum and so much to build on that hopefully the next time I give this talk, I'll have even more to tell you, more good news, and more developments that have made a difference for patients living with MS. So thank you so much.
Thank you, Dr. Bevan, and thank you for all the information. I certainly found it informative. I know our audience did, and it means so much to myself, and I'll speak for our audience for you being here today. Thank you to everyone for joining us today. We do hope this session provided you with some new insights and things you can take back to others in your organization and start having those important conversations to help serve our patients in rural areas. As a reminder, this session was recorded and you'll receive an email to it later today, so you can revisit anything that you found especially helpful. Before you go, please remember, I would really love to hear from you. It means so much to me to get those surveys back and be able to keep these sessions relevant and impactful. So if you could take a minute to fill that out, I would really appreciate it. Also, if you're looking for additional ways to grow your leadership skills or expand your team's impact, please visit nrhasc.com for more educational resources. And if you'd like to learn more about our leadership development programs or discuss how they can benefit you or your team, please feel free to reach out to me directly. I'm always happy to help. Finally, I'd love to extend a special thank you to the National Multiple Sclerosis Society for your partnership and your ongoing support as our nonprofit partner. Your commitment to improving rural healthcare and our patients and fighting for initiatives that impact these areas are so important to us, and your support makes sessions like this possible. With that, everyone have a great day, stay safe, happy holidays, and we look forward to seeing you in the new year. Thank you, everyone.